First stuff to do is fun. Yeah. Okay, cool.
Yes.
All right, for the sake of time, we'll get started. So I'm Dr. Lindberg, and I have the opportunity to introduce our speaker this week, which is Dr. Pecanha from Manchester University. So if many of you know, he's here from the UK. He's been here since Sunday, actually late Saturday night. He'll leave Saturday. So we've had the unique opportunity to have him here actually all week, and he's in the US for another week next week when he goes to the CARNET meeting and visits another lab. So I hope most of you have gotten the opportunity to meet him. Just if you haven't, a little bit of background. So he has his Bachelor of Science in Sports and Exercise Science, his Master's in Exercise Physiology, and then he did his PhD in Sports and Exercise Science from the University of Sao Paulo in Brazil. He then went on to do a postdoc at the same university, but maybe he told you at lunch, he also had a unique opportunity to do a visiting postdoc. So for a portion of his postdoc training, he was at the Liverpool John Moores University, where he was at the Research Institute for Sport and Exercise Science. And this is what opened the door for him to then take a faculty position in the UK. So he's been faculty there now. That position is called a senior lecturer, similar equivalent to what we would think of as like an assistant professor at Mizzou. So he's been there for about 4 years. He's had an incredibly productive career. He's an expert in exercise physiology and cardiovascular physiology. His early work looked at peripheral blood flow and blood pressure control during exercise. And he's recently transitioned to looking at cerebral vascular control, so blood flow control is in the cerebral circulation. He has funding from the Alzheimer's Disease Foundation in the UK. Today we're going to hear about autoimmune disease. So he also has research from the Lupus Foundation in the UK and the Royal Society. So many publications, a lot of significant funding, but anybody who's gotten to meet him is absolutely fantastic colleague. So this week we've been talking about doing research together, collaborations, and he's here has actually funded American Heart Association Visiting Professorship Award. So funding just to come here so that we can meet him, hear more about his research. And one of the cherry on top of his visit is his seminar today. So with that, I will take. Okay.
Thanks very much, Jackie. It's been a pleasure to be here this week. I feel so well received. I keep saying that, but that's true. So I just want to thank Dr. Liebeck, also thank a group who've been quite nice with me. It's been a pleasure for me to stay these days here, to learn a lot from your groups. It's a lot of the responsibilities that you do, and to have this kind of like personal interactions as well. It's quite interesting. All the kind of food experiences as well. It's been quite nice. So I feel quite humble, quite proud, quite happy with the whole experience. Okay. Hopefully you're gonna like what I'm gonna talk about today. So the title of the topic is cardiovascular disease, rheumatoid arthritis, mechanisms and potential role of physical activity. This, so like Dr. Liebeck said, I'm currently based at the Department of Sport and Exercise Science at Manchester Metropolitan University, but majority of the work that I'm going to show here today has been done in the University of Sao Paulo, Brazil, whilst I was doing my postdoc, and now I'm kind of transitioning this work to the UK, where I am also doing some studies with rheumatic disease patients. Okay, so this is where we're based at in Manchester. So we are based in Manchester City Centre. We have a very nice facility there for sport and exercise sciences. We have teaching. We teach sport and exercise science students, sport and exercise nutrition students, but we also do research. And to do research, we have kind of partnerships across different industries, such as football, soccer, like you call it here, kind of like different universities as well, other sports, and also national funding bodies. So it is a very nice facility, and I feel quite privileged to be here as well. There as well, and there's been a lot of investment to do research with sport and exercise science, clinical exercise science. And Manchester is quite a vibrant, quite a nice city to work. So if any of you are visiting the UK, if any of you have any interest to visit us there, please reach out because we also will try to host you as nicely as you're hosting me. Right, this is my lab. So most of my research is the aim is to investigate the mechanisms underlying the development of cardiovascular and cerebrovascular disease or dysfunction in different conditions. So I'm going to talk about rheumatoid arthritis here today, but we also been doing studies with lupus, and we're starting to interrogate about cardiometabolic disease as well, and how kind of brain vascular dysfunction kind of is an important component of the overall cardiovascular pathology in these diseases, and how we can intervene as well with lifestyle intervention. So part of the work is around a more mechanistic side of things, and part of the work is to try to understand how lifestyle interventions, including exercise and nutrition, they can improve cardiovascular and cerebrovascular health in these conditions. The reason why cerebrovascular is highlighted here is because what Dr. Lee Mack said previously. Once I moved to the UK, I felt that the work that I was doing in Brazil, I couldn't get funding for that just because the space of kind of like cardiovascular physiology, there's a lot of competition, there's a lot of researchers working in that space, and I felt that strategically it would be nice to move towards the brain vasculature as a kind of like a vascular bed that's been less interrogated. We don't know to the same extent what improves. We also don't know the effects of some conditions. So if you see the lab that we have there, it's kind of similar to the lab that Dr. Liebeck have here. And I guess there's a lot of crossover between what we do there and what some of you do here. Okay, oops, sorry. So the studies on the research that I do, it sits kind of like between what you would call kind of like a preclinical research, which I don't do, but involves my research, and a kind of a more patient-centered research that I also don't do, but also involves my research. So my research is more on the proof of concept, more kind of like mechanistic studies, but in humans, trying to kind of translate it to kind of like exercise intervention, but it's still pretty much in a controlled environment, even though we also try to go sometimes and do more pragmatic intervention. And we're going to talk a little bit about that later today as well. Okay. Right, so these are the projects that we've been doing in Manchester, in Sao Paulo, I guess, still. So one of the studies that would be kind of one of the topics that we're quite interested to investigate there is the kind of crossover between dysregulation of cerebral blood flow and cognitive dysfunction in lupus. So lupus is a kind of like an inflammatory condition, and they do have vascular impairment, and they also have brain fog. Cognitive dysfunction is a core symptom of this disease. The medications for lupus are quite good to improve the overall inflammation, but the cognitive dysfunction remains. So we think that physical activity might be a good way to intervene as well. So we want to work in that space. We need the foundational work, and there's a little bit of funding coming to do this work as well. There's also the work that we started doing very recently around the effects of obesity and obesogenic behaviors on brain vascular function. So this one is pretty much focused on the brain vascular health. We think that's something new here. And we have some kind of very nice preliminary data to show that obesogenic behaviors, they impair the regulation of cerebral blood flow, even very acutely. So there's quite a nice model of obesity driving brain vascular dysfunction, cognitive dysfunction, which we want to use later to intervene as well to try to rescue with some lifestyle interventions. Unfortunately, that's all I'm going to present here today. I feel that these would have a lot of traction to the research that you do here, a lot of like common ground, a lot of like overlap. But if any of you want to discuss a little bit more about that, I have left my email here as well. We also got funding from the Alzheimer's Research UK to do a study with football and dementia, which is kind of like a different topic if you think about the overall kind of cardiovascular, cardiometabolic disease space. But football is associated with increased risk of dementia. And people think that that's because of the repeated football heading, causing subclinical concussion, causing kind of very minor concussion. It's not concussion, it's more kind of like subclinical alterations in brain function that over time will add up and promote structural brain alterations. So we're doing a study to characterize these alterations, and we're also doing a study with retired soccer players, and we're starting to investigate ways to intervene as well. Okay. And then there is the study, which I'm going to talk a little bit more today, which is the studies with rheumatoid arthritis, and trying to identify or investigate some mechanistic reasons why they have increased cardiovascular risk, and how we can leverage these corticosteroids to improve their cardiovascular. Okay. Right. So rheumatoid arthritis is an autoimmune inflammatory condition, and because it's an inflammatory condition that causes kind of structural changes in the cardiovascular system, and because of that, the cardiovascular risk is increased. It's significantly increased in individuals with rheumatoid arthritis. There are some studies to show that it's even greater than, for example, individuals with type 2 diabetes. So this is just a representation of what I'm saying here, showing the increase in cardiovascular risk, increase of risk is in myocardial infarction, stroke, cardiovascular death, and any cardiovascular events in individuals with rheumatoid arthritis. So they have a greater rate of cardiovascular events in comparison with healthy controls or matched controls. So this is just an award from British Columbia, Canada, but there's a lot of different studies showing that in this disease. Why do they have increased cardiovascular risk? Primarily because of the kind of like sustained inflammation, because the inflammation will link with the kind of like usual kind of like cardiovascular continuum that it follows from, for example, getting older. As you get exposed to cardiovascular risk factors, you do progress from kind of developing endothelial dysfunction, which is kind of like an early stage of the development of the atherosclerotic disease, and that will later culminate with the development of atherosclerosis and cardiovascular events. But because of this rich kind of like sustained inflammatory milieu, that will accelerate this kind of cardiovascular continuum. So individuals with rheumatoid arthritis, they will experience early onset and accelerated progression of atherosclerosis. This has been quite well described in the literature. There's not a lot of novelty here, but this is just to show one way that we interrogate about these changes in vascular function or these kind of like very early alterations in vascular health through the assessment of flow mediated dilation. I'm pretty sure some of you might know what that involves. So this is a technique that to investigate the dilation of an artery following a period of ischemia that follows on a hyperemic response that will dilate the artery. If the artery dilates, that's a good sign. If the artery dilates less, that's a bad sign. That means endothelial dysfunction. So this is just a comparison. It's not even published because this data has been published many times. But with our data showing kind of reduction in flow-mediated dilation in patients with rheumatoid arthritis compared with healthy controls. And that's true for patients that have remission, low activity, or high activity of the disease. So that is kind of like a hallmark of the kind of cardiovascular pathology of rheumatoid arthritis. Right, the interesting thing, so that's when we start to get a little bit innovative here, that the traditional cardiometabolic risk factors, so if you isolate like hypertension, dyslipidemia, like blood lipids, and all of those cardiovascular risk factors, insulin resistance, and even inflammation, all of them together, they don't fully explain the increased risk of cardiovascular disease in rheumatoid arthritis. So there's some missing pieces that we don't quite understand that happens in rheumatoid arthritis that drive this increased cardiovascular risk. Okay? So because of the work that kind of like I've done during my PhD and also some other kind of literature in the area, we thought that it would be nice to interrogate about autonomic dysfunction in rheumatoid arthritis, because that could be a nice piece of this kind of like complex puzzle of the question is why do they have increased cardiovascular disease? So the kind of like simplistic hypothesis that inflammation will drive the increase in sympathetic activity, decrease in parasympathetic activity that will drive cardiovascular remodeling, vasoconstriction, cardiac remodeling, vascular remodeling, in line with the development of cardiovascular disease, just fast, right? So we did publish this journal club back in the beginning of the post, where we tried to kind of explain this hypothesis, because there is a nice link between inflammation and autonomic function. So inflammatory markers, they can affect the autonomic function in the centers, the brainstem that controls the vagus function, centers that controls the sympathetic activity as well. And there is also the other way around as well, that you do have adrenergic receptors in macrophages that will release more inflammation upon in response to sympathetic hyperactivity. You also have the anti-inflammatory vagus effect. So that kind of like loop is probably exacerbated. So increased sympathetic activity driving increased inflammation, and increasing inflammation driving increasing sympathetic activity, for example. So that was our hypothesis. But that journal club is just a small paper that we write in response to a bigger paper that's been published in the Journal of Physiology. And that's the bigger paper that has been published that generated the journal club. So this was the first paper. So this is from James Fisher's group. It was the first paper that have done the microneurography that measured the sympathetic activity in a direct way in individuals with rheumatoid arthritis. But that was quite a nice paper that's quite well published that showed that individuals with rheumatoid arthritis, with or without hypertension, so it doesn't really matter if they have or have not a hypertension, they will have an increase in the sympathetic drive, increase in sympathetic activity compared with normal controls. Okay, this is just representative of data from different subjects, and this is the mean data. You can see here these first two groups are the rheumatoid arthritis groups, and this one is the control group. So higher burst frequency, so more sympathetic activity, higher burst incidence as well. Right. They also show that the individuals can reduce cerebral reflex sensitivity, which means that every time the blood pressure goes up, you don't have the correction of heart rate going down, which is also another kind of like another marker of cardiovascular autonomic dysfunction. Okay. So that was the first paper, and then we just follow up from that paper, and we try to add some interesting information. So the question was, what's driving that sympathetic hyperactivity? So when you start studying about sympathetic activity, you know that there's role of some afferents, there's role of some sensors in the body that can feed back into higher sympathetic activity upon stimulation. And one of them is exercise pressure reflex, which is afferent fibers in the muscle that will sense chemicals, that will sense metabolites, that will sense movement. We call them the type 3 and type 4 afferents, or as a kind of more of a relative exercise pressure reflex. That upon activation, they stimulate sympathetic activity in everybody, but in some conditions, because they have a higher sensitivity, upon stimulation, they will drive a higher increase in sympathetic activity, a higher increase in mean arterial pressure. So the way that you test them is that you do an exercise. We use like a knee extension exercise, 30%. So it's an isometric exercise, 30% of the maximum voluntary contraction, and then you do a ischemic kind of entrapment of the metabolites in the muscles, because you keep the metabolites stimulating sympathetic activity. Hopefully that makes sense. And what we showed was that the mean arterial pressure response was higher during the exercise and during the post-exercise ischemia in the rheumatoid arthritis compared with the control individuals, and the same with the sympathetic activity. So that was the first paper to show that they have higher sympathetic reactivity to these kind of metabolite reflex and exercise stimulation. Okay. So yeah, that was the first study that we done in this area. We also tried to correlate the autonomic responses and variables that we collected and we analyzed during this study with inflammation. So the overall idea here is if it's fast, it's positive correlation. So increases one, the other increases, right? And if low, it's negative correlation, inverse correlation. So here on the bottom, we have sympathetic indexes. So reactivity, so sympathetic activity or heart rate reactivity, blood pressure reactivity through sympathoexcitatory stimulant, right? So if you have an increased inflammation, you're going to have an increased sympathetic reactivity. So there is that link between inflammation and sympathetic, I mean, before. And this is the vagal indexes, so heart rate variability, cardiac reflex sensitivity, which correlates more of the vagal modulation of the heart. There would be inverse with inflammation. So if you have a higher inflammation, you have a lower vagal modulation of heart rate, right? So that's also a nice kind of representation of the links between inflammation and autonomic dysfunction in an inflammatory condition. Right. Then the second study, we now interrogated about another important regulator of sympathetic activity, which is peripheral or carotid camera reflex, which are the sensors that we have in the carotid bodies close to the bifurcation of the carotid artery that sense changes in metabolites, in oxygen. They usually very much characterized as sensors of oxygen. So every time your arterial pressure of oxygen goes down, they will get activated, they will increase sympathetic activity, they will increase heart rate, blood pressure, and they will promote vasoconstrictions as one of the functional effects of sympathetic hyperactivity. Right? That's a okay response, that's not a problem. But like I said before, when it's exaggerated, when the sensitivity is high, that can drive a chronic sympathetic hyperactivity, which is what we find, for example, in individuals with some cardiac conditions, heart failure, for example. Nobody has described this in rheumatoid arthritis, and we're starting to do that study as well. So this is a study that Janara, my PhD student in Brazil, is doing. So she's based in the University of São Paulo, and she's in Manchester doing her kind of like final 6 months of the PhD, and it's been quite nice because now I can do more kind of one-on-one. And then she's doing this study that she's kind of, she doesn't do sympathetic activity, but she measures heart rate, she measures blood pressure with the finger, thermometer, she's measuring blood flow as well. Maybe you can see an ultrasound here, at rest and doing exercise. In normoxia, hypoxia that stimulates the camera reflex, and hyperoxia that deactivates the camera reflex, right? And we just see the responses of heart rate and blood pressure and blood flow. So yeah, this is kind of what I was describing before. She does do kind of rest. She also do exercise. And normoxia, the first condition, hypoxia, the second condition, and hyperoxia, the third condition. But it's all randomized. So the order is a little bit mixed, right? And then she measures all those kinds of cardiovascular outcomes that I was mentioning before, and that also represented in the figure. Okay. We've finalized with 21 individuals with rheumatoid arthritis and 23 matched. I guess it's a nice number for a study of this type. Right. This is very preliminary. So this is not published. She's still analyzing. It's just the first look at the data. Okay. So this is the response to hypoxia. Rheumatoid arthritis here, non-rheumatoid arthritis here. Control matched controls. They're not super healthy. They are matched by the cardiovascular risk factors. So they have the same amount of hypertension, same amount of other risk factors that the rheumatoid arthritis do. The only difference, bigger difference, is that they don't have rheumatoid arthritis. And as you can see here, the response of heart rate is pretty much similar. There's no difference here, minor difference in the overall heart rate between groups, but not of the response of heart rate to hypoxia in rheumatoid arthritis in comparison with the non-rheumatoid arthritis. So when you stimulate the chemoreflex, heart rate responds the same. However, when we stimulate the chemoreflex, so here you have the mean arterial pressure response for heart rate and the matched controls. And then the pressure is usually higher in the rheumatoid arthritis. And then I just said that they are matched by hypertension, but even matched by hypertension, you still have higher overall kind of mean blood pressure values. And when you deactivate, mean arterial pressure is here, they don't hypoxia. When you activate the chemoreflex and you do hypoxia, that decreases in the rheumatoid arthritis, showing a response, which is bigger than the control that didn't show a response. The blood pressure didn't. But that points to a bigger chemoreflex sensitivity, especially when you look at the mean arterial pressure data. Like I said, we still have flows, we can calculate conductancy, so that's coming to kind of get a better view of the full picture. This is hyperoxia. Hyperoxia deactivates the chemoreflex, and that's more interesting in my opinion. So if you look at the heart rate data, when you deactivate the chemoreflex, heart rate decreases in the matched controls. So you deactivate chemoreflex, you reduce sympathetic activity, heart rate goes down, which makes sense. However, that doesn't happen in the rheumatoid arthritis. Which is funny because we thought that would happen to a greater extent in that, because we thought that they would have a greater chemoreflex. We call it here a tonic chemoreflex tone, something like that. So the hypothesis was that if you activate the chemoreflex, because that's exaggerated in the first place in this disease, the heart rate would decay, like it happened here with the matched controls, but to a greater extent. And that didn't happen at all. So we should think about what's happening here. We think that inflammation is a constant drive to increase chemoreflex activation in this disease, because carotid bodies can also respond to inflammation. We have inflammatory markers in this disease. We can do those like colorful graphs that we showed in our other study. So let's see if we can explore a little bit of that. There is no changes in the arterial pressure, so I'm not going to talk too much about this. Right, so just to wrap up, just to summarize this first part of the talk, like I said, individuals with rheumatoid arthritis, because of inflammation, that will drive faster development of cardiovascular diseases, which will later culminate with higher rates of cardiovascular events in this population.
Yeah, next question. If the increase in pressure with hypoxia do you think that's related to peripheral vasoconstriction or increase the cardiac output since our rate was not there?
I don't know. It's so new. Like it's literally. This is more like
the previous one. Still stuck with this one. So
okay.
The rheumatoid arthritis and non-rheumatoid arthritis, they have a similar increase in heart rate, but only the rheumatoid arthritis have an increase in arterial pressure. So it's either an increase in cardiac output or increase vascular resistance.
That speaks to vascular resistance response, right? Because the heart rate, we don't have stroke volume. Well, we do. We can estimate stroke volume with the phenomena data as well. We have this data. So we're eventually going to have a little bit of data in that. But I think that speaks to an increase in vascular resistance if you think that heart rate is a nice part of the cardiac output response.
Okay, that's what I was thinking.
No problem. But yeah, like I said, pretty early on, this data hasn't been presented up to now, so a lot of interpretation to do, a lot of reflection to do. So I think what we'll show, like what the literature shows, is that the inflammation drives cardiovascular dysfunction, rheumatoid arthritis, that's quite well described, but our data, kind of like our studies, they added kind of like a new pathway to explain this increase in cardiovascular. So we did studies with chemoreflex, we did studies with exercise pressure reflex, we did have some nice data showing increase in sympathetic activity. So that's kind of like the first part of the picture. We are currently studying as well the association between this autonomic dysfunction to the regulation of cerebral. So that's the part of cerebral flow that I was talking that I'm kind of like moving my research towards. So soon we're gonna have the PhD second study. She already collected the data as well, EG. She did measure associations between autonomic dysfunction and alterations in principal vascular function. If they transfer, we don't have this data. So the second question is, how do we intervene, right? So how can we break that cycle? How can we improve the cardiovascular function to try to improve the cardiovascular prognosis in individuals with rheumatoid arthritis? I guess the natural way to look at this and to kind of explore some potential interventions about physical activity, just because we are in an exercise science department, right? We do a lot of studies with these type of interventions here. And that's what we did with rheumatoid arthritis. This is one of the studies that we did in this area. It's just a cross-sectional observational study, because we have a lot of patients there, a lot of participants there. So we did have a study with 82 postmenopausal women with rheumatoid arthritis, which we measured the physical activity in an objective way using the accelerometer. And we measure as well their vascular health doing carotid IMTs and informative management. Carotid IMT, we measure the thickness of the common carotid artery, which is a measure of atherosclerosis, to the clinical atherosclerosis. And then we associate it. What are the associations between physical activity levels with vascular health in this population? What the data show, which is a table, it's not a very nice way to show the data, but it's like a table when we do those multiple regression models, is that sedentary behavior, so the time that we spend in sitting or lying down position, either when you see this data in hours per day or as in prolonged sedentary behavior, so bouts of at least 60 minutes of sedentary behavior, correlated inversely with vascular diameters. So if your sedentary time is higher, you have a inward vascular remodeling, which is a kind of a nice alteration linked with cardiovascular disease. Not nice, but pure alteration linked with cardiovascular disease. So that's linked to sedentary behavior. We also measure the associations of these kind of many different vascular outcomes with light, moderate, and vigorous physical activity. And funny enough, with this one, what we show is that the associations they were linked with light and sedentary. So to put this in a very simple way, if you have a high sedentary behavior and a low light intensity physical activity, you would have the worst vascular phenotype. However, if you have reduced sedentary behavior and increased light intensity physical activity, and light intensity activities are kind of easy walks and things like that, you would have an improved vascular phenotype, larger, kind of better, kind of larger diameters, better wall to lumen ratios. So that's nice because that shows, or that is a nice indicator that in this population, maybe they don't need to do vigorous physical activity to improve their vascular health. Obviously, this is cross-section, it's observation, there's no causality in that. But you could say that points to this direction, that if in this population, you reduce the sedentary time and increase the light intensity physical activity, you could potentially improve their cardiovascular health, right? So that's what we did. That's our approach before I show what we did. So these are the kind of usual physical activity recommendations, which asks you now there is this continuum, but it's pretty much focused on attaining at least 150 minutes to 300 minutes of moderate to vigorous physical activity, all right? Although recognizing that every movement counts as well at the same time. So we are more into the every movement counts movement here. So our approach was more around, which I think is more of a physical approach with this population. I'm going to talk about this later. You just ask them, can you please sit more and move? Sorry, sit less and move more, right? So that's our intervention. Is reducing sedentary time and replacing with any activity. Could be light, could be moderate, whatever they want to do, right? So First, we did an acute study that's very similar to some of the studies that Dr. Padilla had done with other populations, in which the individuals with rheumatoid arthritis would come to the lab, and one day they would stay sitting for 8 hours, quite a lot. The other day, they would do a bout of 30 minutes of moderate exercise in the treadmill, and then they would sit for the remainder of the time, right? That's one of the standardized recommendation, like you do 10 minutes per day and 150 minutes of moderation exercise. This one was the kind of like the small steps approach, which is they would stay sitting during the intervention, but at every 10 minutes they would walk for 2 to 3 minutes in a treadmill. So they would break the sedentary time every 30 minutes with a light intensity walk. Okay? So that's what we call the break or BR session. So this is a controlled study. They would do all the 3 conditions in a randomized way, and we would measure. Here we don't have vascular health. That's the only thing that don't add nicely in my presentation here. We were focused on the kind of blood samples to measure overall markers of cardiometabolic health, glycemic responses, insulinic responses, blood pressure. But we also do inflammatory markers. We also do muscle biopsies. I'm not going to show this data. Only data that I'm going to show here today is the glycemic and insulinic responses during the 8 hours. So every time you see a spike here, it's because they have a lunch as soon as they arrive in the lab, and that will spike their glucose, and then halfway through the day they would have a second lunch, and that will spike their glucose and then insulin response as well. However, these increases they were reduced in the breaking intervention, the breaking session, meaning that adding those kind of break of sedentary time improve the cardiometabolic response to amylo, and also to the improvements of intervention improvements. Right? So that would attenuate the responses, the cardiometabolic response to amylo that you would see in a prolonged sitting condition, or even in an exercise condition that was not as good to improve the cardiometabolic health as the sedentary time breaking condition. Is that clear? Good. So that points to our hypothesis being right. So breaking sedentary time could be a feasible and an effective way to improve the cardiometabolic health, right? So the next step, let's do a chronic study then, that we ask them to reduce their time day to day over 4 months, 3 months. I think it's 4 months this year. So we would have many kind of behavioral techniques. They would come and we would do a baseline session with them, and we would interview them. We asked about their behavior. They would be offered a menu, like a list of activities, small activities that they could do that would match their routine. So let's say they go to their work using the bus, and we would ask them to stop kind of earlier to drop out the bus in a kind of like a stop before the one that they usually do, and they would walk the last mile. So that would be one of the options. It might be that they are retired, that they don't work, and that they stay sitting on the couch for most of the evening watching TV, and we would ask them, we might in every break of the TV show that you're watching, we just go and walk. So they would pick a lot of different activities, and we would text message them to remember them to do their activities, to ask if they are doing the activities. We would have meetings every month to ask them about how's it going, to readapt. So let's say they're like, oh yeah, but I cannot do the bus because it's not safe in my neighborhood. So we're like, yeah, okay, so let's try to find another activity. So we were kind of like trying to track them and also measure the activity throughout as well, all these different things. Our idea is our main goal would be to reduce the sedentary time with any activity really in different contexts, transport, work, leisure, social. And we would measure a lot of different things, including vascular function, cardiometabolic health, all these things. However, before I say however, so this is the flow chart. We have like 103 people that were randomized. Some of them were located for interventions, some of them they stayed in a kind of control. And this is kind of like a follow-up. We had a little bit of dropout because of the COVID pandemic. That's another story. But we did finalize with good numbers, so we did have power to analyze a lot of different things. However, that did not work. So that's the time for reality check. So what happens in the lab sometimes don't actually in real life. So they're gonna reduce the sedentary behavior. We looked at sedentary behavior in physical activity different ways. Yeah, prolonged sedentary behavior, hours of sedentary behavior per day, sitting to stand transition. So maybe they are not reducing the overall sedentary behavior, but they at least like not staying too long and sitting position. They transition to a stand position. Nothing stepping, light intensity, moderate intensity, step cost, nothing. Really. That happens, which means that no other cardiometabolic parameters improved as well. Nothing. It's one of the most upsetting studies that I participated in because it's quite challenging. We learned quite a lot. We kind of like approaching this a little bit different with lupus, but not going to talk about lupus today.
If you didn't get the challenge of lack of power.
Yeah. That's a nice review, isn't it? One. We asked them what happened, and that's the problem with, that's the issue with these diseases. They feel a lot of pain, and they have infections as well. So it is quite hard, it's quite challenging to change their behavior. Okay. We did do, I know a lot of things, but we did do kind of split them in the ones that reduced. And we did set this threshold to say that, well, what about if we get the ones that reduce more than 30 minutes per day of sedentary time, which with the meta-analysis showed that that's probably a lot. Well, you can reduce with interventions of that kind, or you can promote some operation. Not much better, but we did see that the ones that if we do this responding versus non-responding analysis, we have improvements in inflammation or borderline improvements in inflammation, and here is just to show some improvements in quality of life. So it's kind of like a multidimensional quality of life assessment that considers different things. And after the intervention, that was okay. I would like to focus in this because the study was not powered. It was not designed to answer this question. It's more on the overall question. So yeah, I guess that's it from me. So some of the kind of like summary of the presentation. Rheumatoid arthritis associated with this increased cardiovascular risk that's been well described. And our data kind of added nicely to this kind of wider clinical data showing that cardiovascular autonomic dysfunction would be an important component of that increased cardiovascular risk. We think that this might be a tool to improve cardiovascular function. Acutely, we demonstrated that even reducing sedentary time, reducing sitting time, replacing with light intense physical activity seems to be an interesting and effective and potentially feasible way to do. But two challenges remain in terms of prescribing physical activity due to this kind of barriers such as fatigue, such as pain, that don't engage in physical activity as much as they should or as maybe other populations do. So I guess that's just that practical challenge of implementing our lab data into kind of like real life intervention, which I guess is a problem that we have across the board. Yes. So the next steps is to describe associations, like I say, between this autonomic dysfunction and cerebrovascular dysfunction. That's not being described at all in rheumatoid arthritis. And they do report greater cognitive dysfunction. They are a vascular impairment condition, so I think it makes sense that they will have some cerebrovascular impairment alterations as well. And then that's one of the things that we need with rheumatoid arthritis, but also with lupus. We think that we need to develop better interventions. So we're doing right now in the UK studies with lupus. At the minute, we're just doing workshops with them, bringing them to the lab, using their input to co-develop a physical activity intervention that is center in their needs, in their symptoms. So we call it the symptom regulated patient center physical activity intervention for lupus and potentially for rheumatoid arthritis as well. And that's how we want to progress in some of these studies in the UK as well. We've done it in São Paulo as well, just trying to keep it the same kind of direction. That's it. I want to thank again everybody for your presence here. Like I said, I need to extend the thank you to Darius as well. It's been great in these last days. Really nice touch and treatment. I'm quite happy to be here also because of how well he's kind of organizing all these activities. Thanks very much, Darius. Thank you for PhD as well, who funded that research. Thank as well American Heart Association, who funded Econ here. And thank you. And if you want to reach out, yeah, this is my email. Thanks very much. Also open to questions.
Great talk, thank you. I got stuck on your kind of the feedback loop that you were talking about with inflammation and sympathetic nerve activity. And then it maybe thinks you have a lot of data in postmenopausal women. And I know that you're primarily dealing with conditions that are very pro-inflammatory. Have you thought about oxidative stress?
Yeah, we did thought about that. We don't have some of those kind of very basic oxidative stress markers. I think we measured some of in one of these studies. I think the intervention study, but
Like
changed it. Never correlated them with autonomic. No, I don't think we did that. But yes, it's another one that's probably a driver of cardiovascular dysfunction in this population as well, because it is, I guess there is the link with inflammation driving oxidative stress as well. So that is probably another result of us.
We can chat more about that.
Sorry?
We can chat more about it.
Yes. Okay, let's do that.
I have a question, or
Go ahead.
no, sorry.
So your patient population, a lot of them are experiencing pain, which is why it makes exercise difficult, but they're probably also taking a lot of anti-inflammatory drugs. So given that your hypothesis is that, it's this inflammation sympathetic loop, do you think that the anti-inflammation drugs aren't just not even enough to overcome the inflammation causing the arthritis, but even enough to overcome the systemic inflammation that is then contributing to this?
I guess I would answer this question in minutes. One, I would say that the drugs is a huge noise nowadays. Because, and that's probably what explains, for example, the camera reflex not being different from the controls. In some cases, they're not being that different because they take a lot of drugs. So they take immunosuppressants, they take biological drugs that targets like specific cytokines, they take the general kind of like non-steroidal anti-inflammatory drugs, they take glucocorticoids, although with kind of limited doses, but they do that as well. They take so much because the hospital that we worked there is patient care hospital. So the rheumatoid arthritis that go to the hospital, the ones that has a kind of harder control. So yeah, I guess that was not the question, but we need to keep that in mind when we are looking at this data. I guess to answer your question, I think that even though the medications are good to control inflammation to a certain extent, even those acute markers of inflammation, they are kind of like a trend towards going back to base. If you see that the cytokines, they're always higher. The anti-inflammatory and the pro-inflammatory, they are higher because they have this higher inflammatory mediator. So the drugs, they improve, they kind of like, they reduce the inflammation, but there's still like overall systemic inflammation, also joint inflammation higher than the controls. So I think that's still a driver of autonomic dysfunction, although perhaps a lower driver than if you didn't have the drugs. And you have like bigger inflammation. I guess. Did I answer the question?
Yeah. Or there may be no true answer to the question, but you provided the context and discussion, obviously.
I had a question about the one that showed if you just reduced or had less sedentary time and just moved more. Was it worse for moderate or vigorous activity, or was there nothing?
There was no association, But there is a problem here. There was the overall level of underage figures were very small. So you don't have that nice spread of the data to the correlation. They were all in the kind of it was skewed to low, very little underage figures physical activity. So I think that's a problem. It's more of a kind of a problem that we don't have power to detect it. It's not that it doesn't happen, it probably happens and it probably associates nicely with a better cardiovascular profile. It's just didn't have a lot of people doing those mobility figures activities, which also is part of a challenge with this population as well.
Yeah, I might have just missed it, but you said you did muscle biopsies on these?
Yeah, we did put together, we did muscle biopsies. What's the question, sorry?
I was saying, what were you looking at?
Local inflammation, like muscle inflammation, it's like metabolomics, there's a lot of different things that responded quite well to the acute intervention, but nothing happens with the chronic intervention as well.
So I really appreciated that when you saw that these changes in physical activity weren't occurring, that you decided to sort of speak to your population and see what exactly they needed to sort of adjust and inform your future interventions. I'm just curious to your process, were you having focus groups or what was your process to sort of gain that feedback and use that to inform future interventions?
That's very new for me, but that's something that's big in the UK right now. You don't design interventions without patient input. You don't even write plans.
Have you heard of community-based participatory research? Are you familiar with that term?
Not with the term, but what does that mean?
Meditation science. Yeah. So essentially it's just what sounds like exactly what you're doing, where you essentially you form they call it a community advisory board. So you recruit people from your population of interest and you sort of collaborate with them to inform an intervention based on their needs. So that's a big thing here. It's community-based participatory research. That was kind of what my master's thesis was focused in. And it sounds like that's what you're doing.
Yeah.
So I don't know if that is helpful for you to hear that term and look into that more, but I think that's really interesting that you're sort of using that feedback to inform future interventions. So I'm just curious to hear more about your process with that.
Yeah, and that's great question. It's also something that, because we're learning now, it's helping so much. So that's the Newton's project now. So we want to do an intervention with the physical activity intervention groups, but we know that's quite challenging, and we know that's good practice to involve them from the very beginning as well. And we think that with that, we're going to do better interventions anyway. So it's a win-win situation, isn't it? So we have this grant now that's just to develop an intervention. It's called that's not what's called, but it's a staged process to co-develop an intervention in patients with you. So it's three stages. The first stage is the part of the patients, just a systematic scope review, just to try to see what things to around physical activity intervention for you. So just describe interventions, not even outcomes. Second stage is a survey. It's a national survey in the UK via Lupus UK, asking about barriers and facilitators, the experience of physical activity. Still very much quantitative, like Likert scales and things like that, but just give us themes to think about for the next stage, which is workshops. So we have two workshops, one in-person workshop, which will probably be more likely to recruit people from the local areas that have lupus, Manchester area, or surrounding towns. It's going to be on the 3rd of December, so we still didn't do, but we are sending invitations now. So we're going to bring these patients to our research institute, and we're going to do focus groups with them. We're going to ask about their experiences. I have a research assistant that is kind of behavioral psychology, so it's much more in that area than I am. I'm just like an admin person and trying to help with the exercise because of my experience. So they were going to do different focus groups with subgroups of patients in the workshop and collect qualitative data about the experiences, about with physical activity, the main barriers that we facilitators, but not in that qualitative way. And then that's one of the focus group. The other focus group will present them an idea that we have of what we want to do in terms of intervention. But that's already formed by the survey. And we're going to ask them to just literally criticize. And then we do that in the in-person workshop, that we use that input to shape the intervention, and later we do a online workshop, just to keep that kind of refinement approach until we start thinking about testing it that works. It's a little bit, as an exercise physiology, that makes me a little bit uncomfortable. Because I was like, oh, but I am the person that knows how to prescribe exercise. All right. But that's interesting to think that's not exactly what having the input from the patient's think is more that their input will form an evidence-based physical activity intervention as well. So and we use a lot of behavior change techniques as well. It's a lot of stuff around that behavior change space that I don't understand quite well, but we're learning and we have people in our team to support that part.
No, I haven't heard about the use of community-based participatory research in this context very much. So that's why it kind of like piqued my interest. But I think it's really cool that that's something that you're working on, and I'm interested to see what ends up coming from that. So thank you for that.
Thank you.
Cecile, yes, very interesting. Oh, thank you. I just had a quick question. I was wondering whether you monitor dietary intake at all about intervention?
Yeah, great question. We did do the diaries throughout as well. That didn't change. I think that was kind of, well, I guess most of the different parts is the chronic study that didn't change. We didn't intervene with foods though. So they were asked to follow their own. We did publish one paper, now I remember, that it's kind of like similar to that cross-sectional paper between physical activity and vascular, that we correlated their food consumption with cardiovascular risk. So it's more of a score phenomenon, kind of like a type of a phenomenon. And we saw that the consumption of ultra-processed foods were correlated with increased cardiovascular risk. But we didn't actively do any intervention following that. It's just like more of a kind of descriptive study that we could do because of our numbers, and we could.
Is there any preclinical model, animal model that can be used to study the cardiovascular effects of rheumatoid arthritis?
Yeah.
Has anyone studied the impact on autonomic function, which is
There is some studies. There is studies. It's a lot of phase studies there. One that I can remember. They measured in the model of the development of rheumatoid arthritis, and they can describe that the autonomic system is quite an early process in the development of the disease. So as soon as they start to develop the first kind of traits, the first phenotypes of the disease, they already have evidence of autonomic dysfunction. So we think it's a key kind of like hallmark alteration of the disease. That's one of them that are going on. There's also studies with humans, that same space, that show that people who have the autoantibody for rheumatoid arthritis that still didn't develop maybe not even develop because rheumatoid factor doesn't mean that we will develop. They also have autonomic dysfunction, so that also speaks to kind of a very strong support. Yeah. Problem.
Very good questions. Well, thank you for your time.
Thanks.